Hello everyone. In today's session we're going to talk about hypertension and pregnancy. My name is Shujauddin and I'm a fourth year medical student at Dow University of Health Sciences. So when I say hypertension, I mean blood pressure of 140 by 90 millimeters of mercury, right? So the different kinds of hypertension that we have in pregnancy include chronic hypertension, which is either pre-existing hypertension or hypertension that a pregnant female develops before 20 weeks of gestation. Pregnancy-induced hypertension, that is hypertension that a pregnant female is going to develop after 20 weeks of gestation without any additional symptoms of proteinuria, end organ dysfunction, or edema or seizures. Preeclampsia is basically hypertension plus end organ dysfunction and proteinuria of 300 milligrams per 24 hours that a pregnant female will develop after 20 weeks of gestation. And eclampsia is basically a condition in which you have all the features of preeclampsia that we discussed just before eclampsia and seizures, right? So eclampsia is basically preeclampsia plus seizures. So let's talk about the different kinds of hypertension and how do we go about them. So in pregnancy-induced hypertension, the patient is initially going to be normotensive. They might not have a high blood pressure. They might be asymptomatic, or they just might have headaches. So it's going to be a vague presentation. They will not have any proteinuria. They're just going to be hypertensive even if they are. And they are at a risk of developing preeclampsia. So when you manage a patient of pregnancy-induced hypertension, you need to monitor them on a regular basis because they're at a risk of developing preeclampsia, which is an emergency condition and it's a severe condition. So you need to monitor them. Apart from that, you have a few drugs that you can give them if their blood pressure shoots up. So the safe drugs to give during pregnancy are labetalol, alpha-methyl-dopa, or nifedipine. The drugs that you need to avoid are ACE inhibitors and ARBs, that are angiotensin receptor blockers, because they are teratogenic. And there is no need to rush the delivery because in pregnancy-induced hypertension, you can easily deliver the baby at the expected date of delivery, so no need to rush the process. Now, coming on to preeclampsia, as we discussed earlier, preeclampsia is basically a triad of raised blood pressure, proteinuria of 300 milligrams per greater than 300 milligrams per 24 hours, and end organ dysfunction. So basically, as you can see in this picture, we have a comparison between preeclampsia and normal pregnancy. So if you notice, in preeclampsia, you have a narrow caliber of your spiral arteries that are present in your placenta, right? So the pathogenesis behind preeclampsia is that you have impaired trophoblastic invasion and narrow spiral arteries, which lead to uteroplacental ischemia. Now, due to this ischemia, you have two things happening. You have vasospasm and endothelial dysfunction. Due to vasospasm, you have end organ dysfunction because of increased peripheral resistance. Due to endothelial damage or endothelial dysfunction, you end up having a increased vascular permeability that ends up giving you generalized edema, right? So the risk factors of developing preeclampsia are previous history of preeclampsia. Secondly, you have increased maternal age, such as greater than 40 years. Any pre-existing conditions such as diabetes mellitus, hypertension, or any pre-existing renal diseases such as glomerulonephritis, or if it's a first-time pregnancy, so you have an increased risk of getting preeclampsia during that pregnancy. So the signs and symptoms of preeclampsia include headache. You can have visual disturbances such as blurred vision, double vision, that is diplopia. You can have photopsia, which is flashing of lights, or scotomas, that are black spots in your vision. You can have right upper quadrant pain, and the reason behind this pain is because of the stretching of your liver capsule, which is basically the Glissen's capsule. So you end up having right upper quadrant pain. You can have nausea and vomiting. You have generalized edema, as we discussed earlier, due to increased vascular permeability. You can have proteinuria of greater than 300 milligrams per 24 hours, and you can also have a blood pressure like hypertension condition which may be of greater than 160 by 110 millimeters of mercury, and if you have such blood pressure, it is known to be called severe preeclampsia. So the investigations that you will order for preeclampsia, you need to keep in mind that you need to rule out HELLP syndrome, because HELLP syndrome is a condition that is basically a complication of preeclampsia. So while ordering its investigation, you need to rule out HELLP syndrome. So you're going to order a full blood count to see anemia and thrombocytopenia, because in HELLP syndrome you have these two things present. Apart from that, you're going to order a coagulation profile in which you're going to look at the PT and APTT. Because of thrombocytopenia, you will have a raised PT. You're going to order a urea and creatinine test to assess the patient's renal functions. You're going to order liver function tests to look at the condition of the liver, and obviously all of these tests were to look at the mother's well-being, but you also need to check the fetus, right? So to check the fetus, you can order a CTG, ultrasound, or uterine artery Doppler. These are a few options available through which you can assess the well-being of the fetus. So in cases of mild to moderate preeclampsia, which is blood pressure lower than 160 by 110 millimeters of mercury with no maternal complications, if you have such preeclampsia, you need to admit the patient to the hospital. Secondly, you need to monitor their vitals on a 4-hourly basis. You need to do a CTG to check for fetal well-being, if the fetus is in distress or not, and you need to check for proteinuria on a daily basis, because we have proteinuria of greater than 300 milligrams per 24 hours, but this value can increase. So you need to monitor their proteinuria, and you need to check for their blood pressure, because if their blood pressure exceeds 160 by 110 millimeters of mercury, you need to go for antihypertensives that we discussed earlier, which are safe in pregnancy. Now, in cases of severe preeclampsia is basically a condition in which you have a blood pressure of greater than 160 by 110 millimeters of mercury. You have maternal complications, or you can have severe proteinuria that is greater than 1 gram per 24 hours, or you can have a second degree proteinuria if you check on the urine dipstick. So if you have that, what you need to do is you need to give the patient antihypertensives, because you need to lower their blood pressure. So give them labetalol, give them IV hydrolazine, give them magnesium sulfate. Now the reason to give them magnesium sulfate is to prevent seizures. Magnesium sulfate is a substance that causes cerebral vasodilation and prevents seizures. Now, if a patient has severe preeclampsia, there are chances that they might progress to eclampsia as well. So to prevent seizures, you give them magnesium sulfate, and obviously you need to go for a CTG to look for fetal distress. And once you have done that, and once the mother and the fetus are stable, you need to go for immediate delivery, that is either vaginal delivery or emergency C-section, whichever is favorable. And if the gestational age of the fetus is less than 34 weeks, you need to administer dexamethasone and betamethasone intramuscularly to promote surfactant production and to mature the lungs of the fetus. Now, the complications of preeclampsia are eclampsia, you can have HELLP syndrome, DIC in the mother, you can have placental abruption, which can lead to fetal death, preterm delivery, fetal distress, and you can also have acute renal failure. Now, acute renal failure is a dangerous condition, because the patient might end up having dialysis and end up having going on to renal replacement therapy. So the conditions that warrant immediate delivery are HELLP syndrome, eclampsia, in which apart from that if you have worsening liver functions or kidney functions, or if you have worsening coagulation profiles, if you have maternal or fetal distress, all all of these are conditions which warrant immediate delivery. So you need to deliver the fetus immediately, because one thing to keep in mind is that preeclampsia is a condition that is present due to the placenta. The minute you remove the placenta, preeclampsia is resolved. So coming on to eclampsia, as we discussed earlier, it is basically a condition with all the features of preeclampsia, and it also has seizures in it, which is why we call it eclampsia. The seizures can be antepartum, intrapartum, or postpartum. So you need to be on the lookout that when are we having the seizures. And one thing to keep in mind, if you have a postpartum female coming to you with the complaint of seizures, you need to make a presumptive diagnosis of eclampsia until and unless proven otherwise. So postpartum seizures, you need to make a presumptive diagnosis of eclampsia. Now, how would you manage a patient of eclampsia? In eclampsia, you're going to start with the ABC protocol, that is, manage the airway, breathing, and circulation of the patient, administer IV magnesium sulfate. You need to give a 4-gram bolus firstly, and then keep a 1-gram infusion over the 24 hours of magnesium sulfate. Apart from that, you need to monitor their vitals, that is blood pressure, pulse, respiratory rate, oxygen saturation every 15 minutes, because this is an emergency condition and you need to monitor the patient very carefully. If you have a blood pressure of greater than 160 by 110 millimeters of mercury, you need to administer antihypertensives to bring their blood pressure down, because high blood pressures can lead to fetal harm. They can lead to placental abnormalities. So you need to manage their hypertension. You need to go for a CTG to check if the fetus is in distress or not, and you need to deliver the baby as soon as possible, as soon as the mother is stable. So emergency C-section would be the way to go about it. Coming on to HELP syndrome. HELP syndrome is basically an abbreviation of hemolysis, elevated liver enzymes, and low platelet count. So HELP syndrome is basically a complication of preeclampsia, and in such a condition you need to go for an emergency C-section. So how would you manage a patient of HELP syndrome? You need to transfuse blood. For that, you need to know the blood group of the patient. So if a patient is pregnant and if there are risk factors of preeclampsia in the patient, so you need to calculate all of that. If she can have preeclampsia, she can go into eclampsia, or she could also end up having HELP syndrome. So know their blood type beforehand, so that in cases of HELP syndrome, do a blood transfusion. Apart from that, administer IV magnesium sulfate to prevent eclampsia. Go for labetalol, because if they have a high blood pressure greater than 160 by 110 millimeters of mercury, you need to bring their blood pressure down. So give them a antihypertensive such as labetalol, hydrolysine, and you need to go for prompt delivery. Emergency C-section would be the way to go about it. So in this session, we briefly discussed the different kinds of hypertension, their investigations, and their management, as to how would you manage a patient of different hypertensions in pregnancy. So I hope the whole concept is clear. Thank you for watching.